Hello, everyone. We're glad you all could join us today. So we're basically going to look at maximizing your male hormones. We talk a lot about female hormones, but it's just as important to look at male hormones because they really do help people be healthy. And a lot of the references are on the slides. Some are from my book, Maximize Your Male Hormones, that just came out. It looks like this. And honestly, it took me 20 years to convince my publisher that men would read a book on health, but it's really an updated version of what happens with men and hormones. So andropause is an absolute or relative insufficiency of testosterone or its metabolites in relationship to the needs of that individual at that time in their life. And there's really a key component to all of this because it used to be that we never saw low testosterone in men under the age of 42. In the last 5 years, that has drastically changed. And it's a separate seminar looking at the idea of what to do with men that are younger that you can't give testosterone to. But be aware that andropause, honestly, it's not just about aging. There's also other reasons why men get low testosterone at any age. 30 to 60% of men in their 70s are hypogonadal. Actually, I think it's closer to 95 to 97%, but a lot of doctors never measure hormones to determine if they're low or not. Testosterone levels decline with aging at the rate of 1% per year, and this decline is more pronounced in free testosterone levels because of alterations in sex hormone binding globulin. And again, half of healthy men from this study between the ages of 50 to 70 will have testosterone levels below the lowest level seen in healthy men who are 20 to 40 years of age. And here's one commonly used graph looking at testosterone decline. The Massachusetts Male Aging Study showed a 30-year fall in total testosterone in men averaging 48% and a decline in free testosterone of 85%. There's also seasonal variations, something we don't discuss, but you can see the references from 1976. So levels of testosterone with peak are found in the summer and early fall, and lower levels in the winter and early spring. So it's important to know how much hormone the patient actually produces. I find this fascinating because when it comes to measuring hormones, there's different ways to measure them. And when people dose, almost always they really don't know how much hormone the patient makes, so then it's hard to dose. Depending on the study that you look at, men make between 5 to 6, 4 to 8 milligrams of testosterone in a day. So if we're using testosterone transdermally, and we're going to talk about how to prescribe, then honestly, more than 50 milligrams would be way too much because you have to account for what gets absorbed into the body. But most people, when they are seeing a practitioner who's not trained in this field, actually end up on too much testosterone. And a lot of that has to do with measuring hormones. So let's stop for a second and talk about measurement. There's 3 ways to measure hormones. You can measure them by serum, you can measure them by saliva, and you can measure them by urine. So what does the science really say? If you put the hormones on the skin, they do not show up in the blood. And I'm going to make a great argument today why you want to put testosterone on the skin, and it's not as efficacious to use it sub-Q, IM, or other modalities. So if you put the hormones on the skin, it does not show up in the blood. You will overdose the patient 99.9% of the time. And there's been 3 studies out on this. The 3rd study is ours. We're about to publish it. We took both men and women. We took all the hormones and we used people of varying ages. And 99.2% of the time, if the patient put the hormones on the skin, it did not appreciably raise it in the serum. So saliva testing is the gold standard. When it comes to cortisol, there are six clinical trials showing that when you measure cortisol, it absolutely has to be salivary. Any other way is not accurate. And that's even in a very conventional approach. When it comes to urine, and I do urine studies, and they're really, really important to look at urine and the breakdown of the hormones, because as you can see, men do make estrogen. We want to look at their estrogen metabolization, its relationship to prostate cancer and other diseases. And that would be a first morning urine. If you want to look at the hormones over time, in 24 hours, then you can look at all of the hormones. That would be a 24-hour test. But we don't dose off of urine. I see many people doing this. Urine is a metabolite. So it's not the direct measurement of the hormone. It literally is the breakdown product. And how I metabolize hormones and how all of you metabolize them are very, very different in each and every patient. So again, if you put it on the skin, it does not show up in the blood. And that's because when you put it on the skin, it goes almost directly into the lymphatic tissue. And so you could stand there with the syringe and really not find it very well. Salivary is the gold standard. Really important to do urine, but we don't dose off of urine because it's a breakdown product and not the direct measurement of the hormone itself. So, having said that, what are the functions of testosterone? Yes, it's sexual interest, but men have receptors all over their bodies. They have testosterone receptors in their eyes. So it does help prevent macular degeneration, glaucoma, and cataracts. There's testosterone receptors on the heart. There's testosterone receptors on the colon. So it helps prevent colon cancer. So again, receptors are everywhere. Testosterone is involved in the making of protein and muscle formation, helps manufacture bone, improves oxygen uptake throughout the body, helps control blood sugar. It's needed for normal sperm development, and it regulates acute HPA responses. It also helps regulate cholesterol, maintains a very powerful immune system, aids in mental concentration, mood, protects the brain against Alzheimer's, and it regulates the population of thromboxanthine A2 receptors. So some references for you. So what are some signs and symptoms of andropause or lack of testosterone? Fatigue, tiredness, and lack of energy is really common. Depression, low or negative mood, irritability, anger, or bad temper. I mean, there is a reason for the term grumpy old men. You know, men who have testosterone don't tend to be irritable unless they're overdosed. Anxiety or nervousness, other symptoms, loss of memory or concentration, loss of sex drive or libido, loss of erections or problems during sex, decreased intensity of orgasms, weight gain, backache, joint pain, stiffness. But if you think about it, and you look at your patients, you do realize this because they didn't have the pain. Their cholesterol, blood sugar, blood pressure, in most cases, really was very normal until their testosterone started declining. And men get loss of fitness. When they exercise, they don't build muscle mass. They feel stressed. There's a decline in job performance. They can get bone loss. So don't forget to do bone density in men. There's a decline in physical abilities, increase in heart disease, cholesterol goes up, blood sugar goes up, increase in insulin resistance, and even metabolic syndrome. So low testosterone very much associated with an increased risk in heart disease. A number of studies here. Studies showed low endogenous testosterone related to an increase in mortality due to cardiovascular disease and other causes as well. Same thing with this study, lower testosterone, erectile dysfunction associated with high cardiovascular disease. So when the patient tells me they have ED, The first thing that I do is not prescribe hormones. The first thing I do is send the patient to a cardiologist, because if they have erectile dysfunction, then they have hardening of the arteries in the penis, but it's not confined to the penis. They have it in the heart, they have it in the carotids. So even before I prescribe testosterone, we're going to send off the saliva test to measure the hormones. And while we're awaiting the results to come back, we have them make an appointment with cardiology to really get a full workup, not just an EKG, but looking at the carotids as well, looking at calcium scores and a stress test. This study revealed that men with coronary heart disease that were under the age of 45 had total and free testosterones that were significantly lower. Same thing here, inversely related to carotid intima medial thickness and plaque score. Low testosterone associated with arteriosclerosis, type 2 diabetes, and metabolic syndrome as well. There's an increased risk when testosterone goes down. Since testosterone's been shown to lower blood sugar levels, the Endocrine Society, and here's the reference, now recommends the measurement of testosterone occur in all men with type 2 diabetes, and that we actually use testosterone replacement as one of the treatments for type 2 diabetes. This study showed the low testosterone predicts mortality from cardiovascular disease. Here, they use serum. The levels were inversely related to mortality, not just from cardiovascular disease, but also from cancer. Same thing in this study. Same thing in this study. We could do this all day. Honestly, I have a 2-hour talk on just male hormones and what happens with the heart. For instance, the incidence of coronary arteriosclerosis, coronary calcium score, peripheral artery disorders, aortic calcification were found inversely correlated with the suboptimal levels of both total and bioavailable testosterone. This study showed that low total testosterone concentrations are predictive of developing hypertension. So is there an association with blood pressure and what happens with testosterone going down? Yes. This is a study from Hart, 2010. Low testosterone is related to also congestive heart failure. In men with chronic heart failure, anabolic hormone depletion is common, and deficiency of each anabolic hormone is an independent marker of a poor prognosis. This animal trial showed the same thing related to memory. In this study, subclinical androgen deficiency has been suggested to increase the expression of amyloid beta-related peptides in vivo. In this study, age-related decline in free testosterone predicted age-related decline in visual and verbal memory. So honestly, when it comes to vision, memory, and mobility, and that is what we think about from an anti-aging approach, vision, memory, and mobility, a lot of it is tied in hormones. And if you ask me, really, if there was 2 things that we could do to really help people be healthy for the rest of their life, it would be hormonal balance and to make sure that their gut is healthy. But they're actually intimately tied together, because all of these hormones, 75% are cleared through the liver, and you may need to do liver detoxes, but the other 25% is cleared through the GI tract. So it's important to have a healthy gut as well. In this study, low levels of bioavailable testosterone, positive predictor of memory loss. Same thing in this Hong Kong study, same thing in this study as well. And you can see they're from very conservative journals. Patients with Alzheimer's have been shown to have a lower ratio of total testosterone to sex hormone binding globulin when compared with age-matched controls. And another trial, there was a prospective longitudinal study looked at the risk of Alzheimer's. Risk was decreased by 26% for each 10-unit increase in free testosterone at 2, 5, and 10 years before the diagnosis of Alzheimer's disease was made. And low levels of testosterone may occur prior to the diagnosis of Alzheimer's. And honestly, they usually do. So another study on Alzheimer's, another one. I mean, literally, we could go on and on when it comes to memory as well. Optimal processing capacity was found in men between the ages of 35 and 90, even after an adjustment for age, education, and cardiovascular morbidity, if they had testosterone. Without it, there is a problem. In men that have undergone hormonal treatment for prostate cancer with suppressive therapy, then they tend to have troubles with spatial performance, with verbal memory as well. Men, when it comes to memory, are different than women when it comes to memory, because male brain is bathed in testosterone with a little bit of estrogen. Men think very succinctly. I always let people know, if men in their lives, if you have a honey-do list, quote unquote, for them to do, you give a male one thing to do, and then you say nothing. When they complete that task, you give them the second thing to do. That's not true of women, because when their brain is bathed in estrogen with just a little bit of testosterone, then women are very different. They can talk on the phone, feed the baby. They can talk all at once at the same time and still understand each other. So men do tend to be more spatial because of the testosterone, but you can see what happens when prostate cancer treatment ensues. That ability to have the visual motor and that ability to have spatial relationships decline. This study shows the same thing. So when we look at replacement and balance of male hormones, let's look at pregnenolone, DHEA, E1, E2, progesterone, and testosterone. We do want to do lab work. We talked about saliva testing. It is the gold standard. People always ask me, do I do blood testing at all? I do for some things, like the CBC and the sex hormone binding globulin and the PSA and the albumin and the FSH and LH and the dihydrotestosterone. But for the rest of the hormones, I never really do blood testing. I start with saliva because then I can compare apples to apples. If I initially do blood and then do salivary testing, then I'm comparing apples to oranges. So I start with salivary, I bring the patient back in, I prescribe their hormones. It does take 90 days for the hormones to balance themselves. So I bring them back in again in 90 days, do another salivary test, and then do one every 6 months. Testosterone is a controlled substance in almost every place in the world now. And when someone is on a controlled substance, then you do need to see them every 6 months. But honestly, I would anyway. Way early on in anti-aging medicine, 30 years ago, we tested people once a year. It really is not adequate. So test the patient, start the hormones, retest in 90 days, and every 6 months thereafter. And then, of course, either you or the urologist needs to do a digital rectal exam every 6 months. Things are changing with PSA. A PSA of less than 4, but rising by 1.5 in 1 year, or even doubling from 1 to 2, that needs a urological evaluation. We used to say the second one here, PSA greater than 4, then they go to urology. But now it's doubling or a PSA above 4. They must see urology and have an evaluation before testosterone can be prescribed. So let's look at estrogens. Men do make E1, E2, and E3. It is important to measure E1 and E2. Estriol is experimental. The only time I prescribe estrogen to men is estriol, and that is if they have multiple sclerosis. Great studies in MS with estriol in both men and women. So estriol, you can still get on the salivary test as well, but for the purposes of hormonal balance, estrone and estradiol. Men do need a small amount of estrogen. You don't want it to be zero because it helps maintain memory and it helps maintain bone structure. Androgens aromatize into estrogens via the enzyme aromatase. So if you overprescribe testosterone, it does not stay testosterone. You're not benefiting the patient in any way. If you overdose testosterone, it converts into E1, E2, and dihydrotestosterone. If you overprescribe testosterone, there's an increased risk in blood sugar, an increased risk in heart disease, and an increased risk in prostate cancer. Early studies showed E2 binding in numerous male tissues. So yes, in men, there's an E1 receptor and an E2 receptor as well. And estrogen's main receptor in men is estrogen receptor 1. It's essential for male fertility and the development of the efferent ductals, the epididymis, and the prostate. Loss of only the membrane fraction of the ESR1 was sufficient to induce extensive male reproductive abnormalities and infertility. So there are estrogen receptors in men as well. There's also a third receptor, GPER, which is extensive in the male tracts, suggesting a positive role because E2 binds to it for that hormone in men as well. We're going to talk about lowering aromatase a couple of different times, but my favorite way, hands down, is Chrysin. Chrysin is so easy to use. It has no side effects at all, and it can be prescribed with the testosterone in the same syringe or pump. It is yellow, so don't let that shock you. The patients usually call me if I haven't warned them, and they say, hey, all of this is yellow now. That would be the Chrysin, but very easy to use. Zinc also helps lower aromatase, flaxseed, EGCG, anastrozole, or related medications. Rarely use those anymore. Causes of increased aromatase, because you can actually aromatize too much, and then you get into too much E1, E2, and DHT, inflammation. Remember, a small amount of inflammation heals, too much causes disease. Obesity, high insulin levels can actually increase aromatization, abuse of alcohol, mold, biotoxins, and chronic inflammatory response syndrome. So there's other disease processes that if the patient has, you want to make sure that you work with them on that as well. Clinical Pearl. It's really easy to do one thing at a time. Then the patient doesn't get confused, their body doesn't get confused. So if I'm going to work on hormones, then I'm not going to work on their blood sugar at the same office visit. I bring it back in 3 days. If I'm going to work on mold or biotoxins, I bring it back in 3 or 4 weeks. If I'm going to work on mold or biotoxins, then bring it back again in 3 to 4 weeks. If I'm going to do toxic metals, then another 3 to 4 weeks. If you do them all at the same time, it never works out as well. Estrogen, again, is important for memory. Here's a great reference. And serum estradiol and testosterone levels have been shown to be lower in men who have Alzheimer's disease compared to age-matched controls. Medications can lower estrogen. Here are some common ones. It doesn't necessarily mean you can take the patient off of them, but sometimes you can find a substitute for them. And then here's the study on MS and estriol in males. Estrogen levels may elevate as men age due not just to aromatization, but also an alteration of liver function, zinc deficiency, obesity, too much testosterone, also ingestion of estrogen-containing foods or environmental estrogens. If you want a list of ingestion of estrogen-containing foods, what they might be, then please email me at faafm63@yahoo.com. So faafm63@yahoo.com. I'm happy to send you a list of foods that are estrogen containing. Patient can eat less of those. There's also foods that promote estrogen to go up. I will send you that list as well. You can also contact your rep, and your rep will have the list. So any of these ways you can get a hold of those. Kind of hard to project on a slide. Estrogen levels can also elevate due to environmental estrogens like plastics and the medications we talked about. Elevated levels of estrogen in males are associated with gynecomastia, decreased sex drive, erectile dysfunction. It doubles the risk of stroke, higher rate of heart disease, peripheral artery disease, coronary arteriosclerosis, insulin resistance, rheumatoid arthritis, BPH, and prostate cancer. There is one physician out there that's teaching the following, because I got a phone call 3 days ago, and it was amazing to me that the more the estrogen, the better. That is absolutely, positively not true. And you can see we have known this since 1996. So you want on the saliva test, your E1 and E2 to be dead center of normal on that test. Here's a study showing an increased risk of stroke if estrogen's high. Here, acute MI. Here, coronary artery disease. Low testosterone and elevated estradiol. Here, an increase in peripheral artery disease in older men. Another study on acute MI. Another one with all these different disease processes. And again, elevated levels of estrogen in men associated with an increased risk in heart disease. We probably have beaten a dead horse here, but please do not let estrogen run high. If it is high, beside chrysin and zinc, and if you've given too much testosterone, lowering the dose, again, you can do an anastrozole, rapeseed extract, wild nettle root, etc. You can also do milka, decrease alcohol intake, losing weight if the patient's obese because estrogen is stored in fat cells, vitamin D, eating organic, vitamin K, and niacin. So in other words, there shouldn't be any patient that has high estrogen. We can fix it in every single one. Men, progesterone is important just like it is for women. Progesterone influences spermatogenesis, sperm capacitation, and really testosterone biosynthesis in the Leydig cells. And progesterone also affects what happens with 5-alpha reductase. It also affects the immune system, cardiovascular system, kidney function, adipose tissue, behavior, respiratory system, and what happens with nerve endings. Progesterone may help with male memory, less on that in the medical literature. So, how about studies on testosterone replacement? Obviously, men need estrogen. They need progesterone. They need DHEA. We could talk for 2 hours, but we are limited to an hour today. So let's look at what happens when we give men testosterone. Erectile dysfunction affects 1 in 5 men, probably more than that, with this frequency increasing with age and the prevalence of comorbidities. And the available literature supports a role for testosterone replacement in men with low testosterone, erectile dysfunction, if they have low libido, and symptomatic improvement. But as you've just seen, testosterone really does help with other diseases. Restoring testosterone levels to normal in men with proven suboptimal testosterone levels here improve libido in most subjects, ED in more than 50% of patients, and it may take 14 to 25 weeks before the effects of testosterone for this reason become manifest. Testosterone replacement does help with cognitive function. Here, it helps prevent beta amyloid plaquing. The study showed the testosterone in elderly men showed some reversal of cognitive dysfunction. I use this in conjunction with pomegranate juice. Some great studies on pomegranate juice reversing plaquing in the body in both men and women. So I personally drink 2 to 4 ounces of pomegranate juice every single day. Testosterone has been shown to help with mild cognitive impairment. Animal studies have shown testosterone replacement can improve memory, possibly by reducing beta amyloid plaquing. And here, testosterone in older men improves spatial cognition and verbal fluidity. In older men with dementia, testosterone reduced working memory orders. Or errors. It really doesn't change and totally reverse cognitive decline, but it is helpful. In this trial, testosterone improved verbal and spatial memory. Here, testosterone has been shown to help with global cognitive function. And the findings of the study suggest that in the context of high cortisol, testosterone may be neuroprotective. Remember the hormones, it's all about balance. It's all about balance. So if you replace testosterone or not, does impact what happens with cortisol. So in other words, if the patient has low testosterone and it's not replaced, it literally is a stressor to the body. This study from 2016, promising associations found between cognition, testosterone supplementation in men. Short-term administration of testosterone when it comes to the heart induces a beneficial effect on exercise-induced myocardial ischemia in men who have coronary artery disease. It has a direct coronary relaxing effect. This study revealed that testosterone replacement was associated with a decrease in HDL-C and lipoprotein A. Honestly, it's hard to lower lipoprotein A. Niacin in high doses works very well, but statin drugs raise lipoprotein A. One way to really lower lipoprotein A besides niacin is to make sure the patient has testosterone. The mechanism of testosterone replacement decreasing lipids may be due to testosterone's positive effect on abdominal fat and insulin resistance. Short-term administration of testosterone induces a beneficial effect on exercise-induced myocardial ischemia. And in this study, short-term intracoronary administration of testosterone actually caused vasodilatation. Low-dose supplementation with testosterone in men with chronic stable angina reduced exercise-induced myocardial ischemia in this study as well. So several studies showing that. Testosterone replacement has been shown to increase coronary blood flow in patients with coronary artery disease, and another study on increasing angina-free exercise. Studies show that testosterone replacement reduced exercise-induced myocardial ischemia. Here, vasodilatation. This study modulates what happens with cardiovascular disease when you give testosterone. Here, it decreased inflammation and it lowered total cholesterol. Because honestly, having high cholesterol isn't what causes heart disease. It's inflammation of cholesterol. And that is how a statin drug works. It decreases inflammation. Well, testosterone does too, as does DHEA, as does cortisol, as does pregnenolone, as does melatonin. They're all anti-inflammatory. Testosterone replacement can suppress the levels of circulating pro-inflammatory cytokines. It doesn't, however, have an effect on C-reactive protein. Mortality-related cardiovascular disease was significantly reduced in the group receiving testosterone replacement. The estimated reduction in mortality for the testosterone group was between 66% and 92%. There were also 30 non-fatal strokes, 26 non-fatal myocardial infarctions in the control group, but the group that was treated with testosterone, they didn't have any. But I still have cardiologists, and other kinds of physicians calling me and saying, oh, he has a high calcium score. He can't have high testosterone, or he can't have testosterone replacement. That's not true. Testosterone replacement has been shown to improve myocardial ischemia in this study, and the same thing in the TRAVERSE trial, which is now going on. It started in 2018, and it's showing so far that supraphysiological doses of testosterone actually increase the risk of heart disease. The FDA now says the number one drug of abuse is testosterone in both men and women. But a lot of that has to do with people not using salivary testing. They're not testing, or they're using serum. They put the hormone on the skin. It is not showing up in the blood, so they just give more and more and more. And again, it does not stay testosterone. It converts to E1, E2, and dihydrotestosterone. Patients with elevated DHT have an increased risk in prostate cancer and heart disease, so you don't want to drive up DHT. Great study looking at testosterone and congestive heart failure. It was shown to be helpful. And testosterone-treated group in this study had significant improvement compared to placebo in a 6-minute walking test. And another randomized controlled trial on patients with CHF, testosterone over 3 months resulted in a significant improvement in diastolic function and walking score also. Here, an improvement in muscle performance in people with CHF. How about testosterone with inflammation? Testosterone suppressed circulating levels of TNF-alpha, which is a major inflammatory marker. There is no clinical evidence that the risk of either prostate cancer or BPH increases with transdermally applied testosterone replacement. So we're going to talk more about transdermal application. Interestingly, men that are older with the highest risk of prostate cancer have the lowest levels of testosterone. Several studies have shown that in the presence of significant insulin resistance, testosterone replacement increases insulin sensitivity. It improves blood sugar in patients with type 2 diabetes. That effect is evident after 3 months and maintained for up to 1 year. When it comes to insulin, testosterone replacement decreases insulin resistance. However, supraphysiological doses of testosterone increase insulin resistance. So hyperinsulinemia decreases testosterone and replaces, when you give testosterone, the replacement decreases the hyperinsulinemia. I'm going to say that again because it's so important. High insulin decreases testosterone. When you give testosterone, it brings down that insulin. This study from 2021 suggests that testosterone replacement therapy should be considered as a treatment for people who have osteopenia and osteoporosis. So when we actually give testosterone replacement, is it safe? Yes. We've actually been replacing it in patients for 70 years. It can be replaced as a cream or a gel. We're going to talk again about pros and cons. I do like to have mine compounded by a compounding pharmacy so I get the right dose. If you use testosterone made by a pharmaceutical company, the doses tend to be very high as a gel. When you use it made by a compounding pharmacy, it is customized and individualized for each and every patient. This study is usually the one that convinces patients that testosterone should go on the skin. If it's put on transdermally on the skin, for ED, it works 81% of the time. If you use it orally, which I never see, 51% effective, IM or sub-Q, 53% effective. When you give it transdermally, it mimics what happens in the body. Because testosterone in a male changes his dose 4 to 6 times a day. It's very, very subtle. When you give it sub-Q or IM, and we've tried many different ways. Early on, we gave it twice a month in bigger doses, IM. Now, commonly used sub-Q twice a week. So when you give it that way, what happens the first day is usually the man has too much. The next day, he has the right amount. And the third day, he has too little. So you kind of get a roller coaster ride. How do we know this? We actually did saliva testing on men every single day of the week, and that is what we found. So the doses of testosterone is usually 5 to 50 milligram cream or a gel. There is no one that you cannot get testosterone into. I usually put my hormones in Versa base, VERSA base. However, if you can't get testosterone into a male, it's also true of women. Haven't had to use this base in women, but about 80% of my men are actually on a base called Atrevis, ATREVIS. It's a gel. It is made totally for testosterone. It will drive it into the skin, no matter how thick it is, and no matter how much hair the man has. Applying the gel on the inner thigh or top of foot is usually the locations where men have less hair. It does work best. Again, you can add Chrysin if estrogen is high. It has that yellow color, and the dosages of Chrysin depend on what the E1 and E2 are on saliva testing, and they're usually 5 to 50 milligrams. Testosterone does come as a gel made by a pharmaceutical company. Does have some side effects because the dose may be a little higher depending on how many grams they're using: nervousness, gynecomastia, headaches, acne, insomnia, and the things that you see here. Here's a transdermal application with a patch. There can be skin irritation, depression, headaches, and dermatitis. Don't see that when we use it as a compounded gel. Transbuccal tablet, side effects here. Tried this once, the patient got major gingivitis, and really you get stinging of the lips, can be possible side effects. No need to do it as a buccal system either. And then there's IM and sub-Q. These are just different forms that are available for the patient to use. If it says on the package insert IM, I see some practitioners change that to sub-Q. Please do not do that. If it says IM and the patient gives it sub-Q and they get an abscess, and then you are legally liable for how you directed it. So here's kind of a summary slide of different ways that drug companies make testosterone. There's a topical solution. So individuals treated with testosterone replacement, again, should be monitored. We talked about that in 90 days. And a repeat saliva test every 6 months. You do want to do the 2, 4, and 16 hydroxyestrogen in males. The 2 is what they want. They need a little bit of 16 to maintain bone structure. Too much 4-hydroxy, or actually any 4-hydroxy, increases the risk of prostate cancer. So you do want to look at estrogen breakdown as a first morning test in males as well. If the hematocrit rises above 54%, the treatment should be discontinued. Understand, discontinued. Underline, discontinued. Not cut down, but discontinued. The patient may need to donate a unit of blood. They commonly do in order to lower their hematocrit. The patient should discontinue testosterone and see a urologist if their PSA is above 4 or it doubles. The clinical response to transdermal testosterone is variable for different things that you're trying to treat. So it does take 4 to 12 weeks to restore the serum testosterone concentration to physiological ranges, depending on the initial concentration of the hormone. The lipid profile begins to improve in 3 to 4 months, with maximum effect obtained in 12 months for total cholesterol, 22 months for triglycerides, high-density lipoprotein, and low-density lipoprotein. It's important to advise the patient of this so you set the right expectations, because if you tell the patient, oh, everything's going to be great in 90 days, that's not true. A decline in fasting blood glucose and hemoglobin A1C may be observed after 3 months with further decrease in 1 year. And the effects of testosterone on bone density take longer. It may take 6 months to see the initial effect. It may take 3 years or longer to have the beneficial effects. And patients with metabolic syndrome, looking at benefit in waist circumference, blood sugar, and blood pressure, it does take about a year. This one is one that my males like. Improvement in sexual desire usually occurs in 3 to 6 weeks, so they do not have to wait for that one. These are counterindications to testosterone use: prostate cancer, breast cancer, prolactinemia, prostate nodules or indurations that are not investigated yet, uncontrolled or poorly controlled heart failure. You can use it in heart failure. As you can see, it helps, but control the heart failure first. Hematocrit above 50, we talked about PSA. Severe BPH, haven't had that issue. You should treat the sleep apnea first. So severe untreated sleep apnea is a counterindication. Treat the sleep apnea first, then prescribe the testosterone. Severe liver and kidney disease, so far personally, that's not been an issue with my patients. Most of them try and come to me healthy. Only once did I have severe kidney disease. The patient was also already on dialysis, so in that patient, it did not matter. So he did get testosterone. New therapies, they're looking at a whole lot of new things that are being considered. Nasal testosterone, newer oral formulations, different kinds of anabolic androgenic steroids. Lots of studies are occurring right now. Just to reiterate, having erythrocytosis is associated with an increased risk in the development of heart disease and thrombosis. Erythrocytosis is usually secondary to an overdosage of testosterone. So start low and go slow. I cannot say that enough. Start low and go slow. If too much of testosterone is there, stop the testosterone and have the patient donate a unit of blood if their hematocrit is elevated. Major study on the risk and benefit of testosterone replacement suggests a baseline hematocrit should be checked at 3 and 6 months. So they're now coming out with criterion. So again, that's how often you have to see the patient. We talked about measurement of hormones when the hormone is put on the skin. And I hope I made a great argument today that testosterone really is best on the skin. Then you really can't use serum testing and be accurate because it doesn't show up. If it does, very little increase. Salivary testing is the gold standard for cortisol. We didn't have time to talk about cortisol, DHEA, or pregnenolone today, but cortisol has to be measured by saliva. And because the hormones go directly into the lymphatics, if they're put on the skin, then saliva test is really the most accurate form. Urine testing is important to look at for 2, 4, and 16 hydroxyestrogens and other metabolites of the other hormones, but we don't dose off of urine because it is a breakdown product. So in conclusion, and then we're going to open it up to questions, maintaining optimal hormonal levels in men, essential therapeutic tool to aid the patient in achieving optimal health as well as preventing disease. It really is the ultimate in an anti-aging personalized medicine approach. So we're now going to open it up to questions.